you're doing the monitoring, is it showing whether the brain is calm or not calm? We missed the beginning as we went to the long room.
No, it's a great question. So we're actually
We're getting to that part.
we're feeding right into it, so it's a great segue, if you will.
You said sometimes we use deep breathing. Is that supposed to be relaxing the brain or not?
Right. No, wonderful question.
So with the activations that we do, some of you might wonder, why do they get such weird instructions before we go to the EEG? Like, don't put gel in, make sure your kid stays up till midnight and wake them up at 4, things like that. Because we want to try to create a similar environment in the brain as there is when the patient is having a seizure. So with sleep, for example, a lot of seizures happen at night when people are sleeping, and so we want to try to get sleep-deprived patients so we can get them to sleep in EEG. With the deep breathing, the hyperventilation, hyperventilating changes the chemical environment of the brain. It gets rid of CO2, carbon dioxide. And changes in the chemical environment as well as other changes in the brain can induce seizures as well. So with anyone familiar with absence epilepsy or absence seizures, the staring spells, 80% of people who have those seizures have one when we do the deep breathing exercises. So it's an extremely powerful tool for us to help elicit that kind of seizure, because if we can elicit it and repeat it, the doctor can see it and know exactly how to treat it.
Now, I've heard that deep breathing, like every hour, can help people never to have a seizure. So it seems like you're saying the opposite.
Again, with absence seizures, the absence epilepsy, where patients will stop what they're doing and just sort of blank out like that and have staring spells or daydreaming spells. Those types of seizures are very responsive to the hyperventilation exercise, but not all seizures are. There's somewhere around 40 different types of seizures, and they all react differently to different things.
Sure.
So if I may,
Hyperventilation.
Hyperventilation is the deep breathing exercise, so
You're breathing in and out deeper and faster than you normally do. And so you're trying to blow off all the CO2 on the brain during the exercise. So it's not like a meditative breathing exercise.
that's where I was just gonna,
It's
exactly.
two different things.
You need to have specific definitions of what you mean by deep breathing. What you mean deep breathing is you breathe in and you expand your lungs and your stomach,
So,
and
if
then you let it out slowly.
Right.
You're talking about
Like almost like you're doing a running, short little marathon or something, that type of breathing. Where you're tired.
It's definitely different. So your technologist, when you have a procedure, should explain to you what hyperventilating is. It's deep breathing, it's rapid breathing in a short period of time, usually about 3 minutes. It may be repeated or not. In a meditative state, it's slower, deep breaths, more of a relaxation type. So there are variables and there's differences to that. It's a great question, but there is a definite distinction between the two.
Excuse me. Yes. I'm the next speaker on the EEG. I want to show you, this is not like a meditative exercise. This is to induce an abnormality. You are going to deliberately breathe very deeply and very fast. The idea is to get your carbon dioxide in your system much lower than normal. Right? Some people would get a little dizzy when they do that. But it's not normal, healthy, wholesome exercise. We are trying to bring out abnormality.
Correct. Hence the reason for you may have a flashing light. A strobe light, different frequencies and duration, the deep breathing, and sleep deprivation, as Jay was talking about. You may have a normal EEG while you're awake and abnormal while you're asleep. You may not necessarily have an event while you're sleeping, but your brain activity may change and show something that may be indicative of something like a seizure. So those are the things.
In other words, you don't have to have a seizure during an EEG to determine that a person has a seizure disorder. Sometimes the brain will put off these little waveforms that aren't a seizure, but that tell the physicians that this person has a seizure disorder without actually having a seizure.
Are those called spikes?
Spikes, yeah, you'll hear spikes, waves,
Sharp
sharps.
spikes.
Yes.
Right. We don't really get into the EEG component in here, which may be something for future reference. We're trying to give you sort of a perspective of who we are and what we do. So some of the things I'll go through before we start getting into who we are. It's just about the procedures. After having an EEG, it's what are the next steps. We'll have a physician look at the EEG, assess and say, okay, based on the findings, we would like to do this, or we'd like to have you an ambulatory EEG, or we'd like to have you admitted to the hospital for long-term monitoring, or go into an epilepsy monitoring unit in EMU. So just so you know the importance of that, the first thing is finding out, okay, on the EEG we may have, in that short period of time, some contributing information, or we may not, we need to do further assessment. So ambulatory EEG, has anyone had an ambulatory EEG done? Okay. So you go home with the device, recording your brain activity, and then come back, and then that data is then assessed, right? And then based on those findings, we may or may not capture what we're looking for, and then a patient it may be decided by your physician then to be admitted to an epilepsy monitoring unit or for long periods of time. So just so you get an idea, when you come into an EMU, if you will, just the role of a technologist, we are there on a daily basis, if not every few hours, once the electrodes are placed, ensuring technical integrity, monitoring your brainwave activity, as well as while you're being recorded from a video standpoint, to make sure that we ensure safety, patient safety, and the events that we capture, we simultaneously are able to see the clinical behaviors as well as electrographic changes at that point in time. And this is just it's a multidisciplinary approach. So there's going to be your physicians coming in, nursing is going to be coming in, your technologists will be coming in. And this can be done in an ICU setting as well for us from a technologist standpoint, being able to record 24/7. This is a little bit about what we had talked about just from a long-term monitoring standpoint. Here is just giving you some examples of our role of monitoring and some of the setups that are across on a national level. There can be many monitors for each patient being reviewed at one point in time. And then there's a little bit of just some information about actually what it looks like to recording directly from the brain. Anything you want to add to an EMU? And then knowing that also too, we can do this in an emergency room as well as anywhere within a hospital. In the OR, we play a large part in there as well. There are some other types of what we call modality or procedures that a technologist can be skilled and trained in, and one of them has to be evoked potentials, which I don't think we really need to get too in depth with, but it's just stimulating a nerve and then following that pathway up to the brain. It should happen within a certain time frame. I think more it's on the adult side than it is from the pediatric point of view, but it is something to assess. And that a technician would be responsible for it. Or in the OR for any type of spinal surgeries, acoustic neuromas, anything along those lines. Anything you would want to add to the OR piece?
With auditory evoked potentials, I've done that quite a bit to help rule out hearing deficits with children that may or may not have autism as well. So since autism and epilepsy also run hand in hand, that may be something that is seen as well.
Even in a neonatal unit in an ICU, they may do that sometimes. I'm dating myself, but there was a study with antibiotics. It was Ampigen at that point in time, but looking to make sure that pathways were not affected in these babies that were given this medication. Just to give you an idea of the tools that we use, right? Like we had said before, we're not shocking you, nothing's going into you when we're doing an EEG, whether it be short-term or long-term. And then Jay, do you want to go through any of this stuff? If anyone has any questions about it?
So these are the tangle-resistant electrodes.
I think that's the biggest challenge, right?
Yeah. Just our like I said,
and those are actually
standard
the no-tangle ones. You got in there in hand instead of...
I love these ones. But these are just the standard electrodes that we'll put on your head. When we put them on first start, we'll use something like this here to do prep, or there's other things, ones that smell like lemons, some that are slightly less abrasive, but it's just kind of like a little exfoliant that we put on, and we use a Q-tip to just rub over the area. So this way we can remove oils from the skin, dead skin cells, and it helps.
The red marks would mark on your head, you know.
Right.
Get that off, and yeah.
And it helps lower what we call impedance, which is just anything in your scalp that might block those electric signals from your brain. Okay, so we use this to just help the electrodes get better contact. After that, we put the paste that you guys probably really hate, right? And the reason why we use this is because the signals from your brain are just really, really small. And the paste helps those signals get to our electrodes, to our wires faster and more completely. So it helps conduct it better, so that way we can actually record the activity from your brain. Otherwise, it'd just be really hard. Aside from that, can I lift this one? We have our tool belt tools, our measuring tape, and our China markers is how we put the red marks on there. And this is what I think any good tech really needs to be able to use to make sure that we put these electrodes in the right place. If we just slap them on anywhere on your head, then we're not doing you any kind of justice. We have to make sure that they're placed like that map, that head map that Mary showed earlier, in very specific locations, spaced out to very specific proportions. And the reason why we do this is because we've learned, we as in this, people in this field have learned over time that certain parts of your brain are specific to certain activities, and certain seizure activity happens in certain parts. So we want to make sure that we record them properly so that they're symmetrical. It's like Mary said, different parts of the brain do different things, but they should be doing the same thing on each side of the head. So this way we can compare. If someone has temporal lobe epilepsy, we want to make sure we're comparing their temporal lobe to the temporal lobe on the other side, right? And just some of our tools that we'll use to make sure that we have everything on. We have it properly.
There's different types of pastes, and some are easier to get off, others aren't.
Okay, perfect. So now I want to give you a little bit of background about how, for us, the type of formal training, education, just so you understand who we are and what we're doing. Currently, right now, this field has been evolved over the years, where it used to be on-the-job training was acceptable. In the last couple of years, we've moved to a platform of looking at either having some type of formal training, the years of experience that you have, and then also credentialing. So similar to like nursing, where you have to go for your registry, our credentialing is we would have to go for a registry in any of the modalities that we would like to do or conduct. EEG is the golden standard, and it's a blanket type of credential that would say, yes, with this credentialing, you can do these other procedures, but the preferred mode may be that you are registered or credentialed in any of these other type of modalities.
So that's one thing too, as a patient, you can go in, because as you see up there, it says, we're not licensed and we're not regulated, okay? So if you go in and you're not feeling like you're getting this temporal lobe, this temporal lobe, because they're not marking, you can ask, are you asked your tech? Feel free to ask, are you registered? You know, what kind of training do you have? And I've literally been at places where, you know, they had to remove one tech and bring a different tech in or reschedule the patient because that patient wanted somebody who was formally trained or had been board certified. You have the right to ask that. You don't have to just accept that tech that walks in. And yes, there are techs who have not been formally trained, have had, unfortunately, very little on-the-job training. It happens out there. So you have the right to ask that. Okay, and that's one of the things ASET Society is working on in the state of California. We are actually we're moving towards the licensure. We have a lobbyist now. I know some of you guys have heard me talk about that in the past. in the state, we're getting closer, much closer to getting the state regulated in our field. So
Are you trained in sleep disturbances and sleep apnea testing?
Some of it.
And
So
can you tell the difference between a sleep disturbance and a seizure?
Yes.
sure, you can go on that. I will add in.
Okay, so yes, we are trained to recognize stages of sleep and certain sleep disorders. Some schools have specific training regarding sleep and sleep disorders such as apnea or parasomnias, sleep pathologies. Not all techs, not all schools may have equal education in that. However, let me give this huge caveat here, okay? We may be trained to identify activity on the EEG so that we can better show our physicians activity that we feel is important, but we as techs are not the ones that are there to interpret or analyze the EEG. So even if I can read an EEG and say, I don't believe that's a seizure, I believe this is some sort of sleep activity, I would then go to my physician and tell him, I thought this was interesting, take a look at it. But I'm not the one that's going to make that, regardless of what my skill level or my confidence level is, because it's outside of my scope of practice.
So the neurologist, if you have that situation, and you have experience with it, and notifying the neurologist, and maybe it's a sleep disturbance, does the neurologist tend to want it to be a seizure disorder? Or will they actually go and say, let's do a sleep study?
They'll look at the EEG, and if they feel that it is something that is more related to a sleep disorder rather than a seizure, then they may
send you to a sleep center for a sleep apnea or an overnight 24-hour study, which is polysomnography, a polysomnography test compared to an EEG. They're similar but different.
See, where I'm coming from is my son here. I thought he was having seizures in the morning. When we find out he had the most severe case of sleep apnea, and the sleep apnea, the choking, loss of oxygen, startled him during his sleep, and then he had a seizure. So with a BiPAP machine, he doesn't have those seizures in the morning anymore.
That's great.
And I am still holding a lot of anger for when he was tested in a hospital for several days, and they never checked. When he only has seizures at night, it would make sense that everybody who has seizures at night should be studied for sleep apnea, in my opinion.
Part of the reason for something being missed in that situation, I'm not saying this is certainly what happened, just an analog to it, is that with polysomnography, when someone goes in for a sleep study, the reason why polysomnography is so different, the reason why it has its name, polysomnography means mini sleep writings, is that polysomnography doesn't just record from the brain. There's also belts that go over the abdomen and the stomach, and then there's electrodes that go on muscles in the legs, a sensor for snoring, and other sensors that go under the nose and mouth for breathing. And those extra sensors, ones on the stomach and chest and under the nose and mouth, are what detect breathing abnormalities like apnea. So when someone decreases their breathing or stops breathing, those sensors are needed to check. So if someone were to go into an EMU or ICU and have an overnight or several day study, or even on ambulatory studies, if they don't have the extra respiratory sensors, then an apnea can't be detected.
So that testing, why can't both testing be done at the same time, the EEG along with the sleep study?
I believe that would be what the doctor feels is indicated.
So it depends on where you're at and what center. I mean, and we can take this offline because there's many things, but it's just a matter of, one, I'm grateful that it was able to be determined what was the cause, right? So you do get to the bottom. Right, true, and hopefully it won't be that way for someone else based on what is known. There can be events out of sleep that can mimic seizure activity, or someone to have an event that looks like a seizure, but it may be related to sleep. And being able to decipher and differentiate that is really having the right type of testing done. And I don't know where you are, but I'm glad it was resolved. But things have evolved and advanced. There's many contributing factors to help get to that diagnosis.
And and it takes time too. I had a family member went through the same thing, had been diagnosed with a seizure disorder for decades. And it wasn't until he was in his 60s that he finally went in for, we knew he had sleep apnea, but he never got tested for it. When he got tested for that, once he got tested for that, he no longer had seizures during his sleep. So it was the sleep apnea, deprivation of the brain, whatever that was triggering the seizures. But it's taken time too, where the problem with the new technology and evolving things is learning how the different pieces work together. And unfortunately, you have to go through a period where people are going to get missed because they're learning how sleep can impact seizures and seizures can impact sleep. And it sometimes takes time to figure it all out.
But every neurologist will tell you that sleep deprivation leads to more seizures.
Yeah.
So it just makes common sense to check out someone else's sleep. And I just want to ask, because I wasn't sure of your answer, is it possible to do both tests at the same time during one night?
It can be. It depends on where you're at and what your
So
physician
I just
would
want to
like.
know if it's possible.
It's possible. You may have some limitations depending on which, how can I say this, which procedure is going to carry the most weight. But it's going to be a matter of where you are, where you're seeing, what your physician would like to have done.
And the way sleep recording's done is different than like a sleep system runs and operates differently than an EEG system. That's why typically you don't do both at the same time.
It depends on where you are.
And where you're at.
So just to go back to the technologists and credentials and training, I just want to make sure, so we're actually here and representing ASET, which is American Society of EEG Technologists on a national level. And just so you know what the field entails and understanding the career once you're in it and many different paths you can go on. We're all in the field and we actually each hold different roles in where we are. I've moved from one academic center to another. And this is my third academic center. I'm at UCSF currently. And I evolved into looking at the bigger picture to strategic planning. How best to make sure you as a patient, once you've seen your physician, get through the system into a surgical case if needed, or just looking at that. And so it's a larger operation. And then we have technologists that are doing direct patient care and are proficient and skilled in that. And then we have technologists that are running programs. So once you get into this field, I honestly, just my personal opinion, you have a job for life. There is a need on a national level for technologists as programs are continuing to grow as the field has evolved. This platform for this expo has grown tremendously over the years, and we have greater engagement to share and educate so patients or family members, loved ones are aware of what choices they have to empower you in the decision making for yourself or for someone else. So I wanted to put that out there. I think this is a great opportunity. When we start getting into some of the credentialing and training, here are some of the things that may support, and Jake probably can get into this a little bit better, but looking at schools on a national level, we really do not have that many schools. California, I believe, only has 2 at the moment.
Fully accredited.
Accredited programs.
Which means that they've been recognized by Calamity, TNK, have organizations that say this school does it right.
Right. And you think about it, California is a huge state, and we have a lot going on here on the west. And then the schools, if you notice, you see these little stars. This is actually an older map, but still depicts that majority of the schools are on the East Coast.
So you got one here, and you got one in here,
Yeah.
for the whole state of California, nothing in the bottom here.
So we're looking at efforts to try and have a school. The organization, ASET, has also worked with a credentialing body, which is ABRA, American Board of Registered EEG Technologists, to look at some creative ways, online programs, how to collaborate with larger organizations or community colleges within the area. But knowing that these even exist, I think is one of the biggest things in how do we put out heightened awareness. And usually people, to get into this field, it's usually by happenstance, like, well, they have a family member or themselves have been directly affected. And so Didn't even know this career, this field even existed. Do you want to add anything about the schools?
Can you go back one slide?
Sure, absolutely.
So as far as the schools go, most accredited programs are either going to be associated or diploma programs. The associated degree programs are going to be anywhere from 18 months to 2 years, depending on how the school's set up. We have currently 2 bachelor's level programs that do require people already have experience and credentials in the field. Those are ESET and for the other one is
I'm trying to like up on
Third
there.
wave too.
it's Holy Cross.
Somewhere in there. But it's not on the west,
But it's not
that's
on
for
the
sure.
west. So it's here in California, there's Orange Coast Community College, and in the city of Orange and Concord Career College in San Bernardino, both carry their pros and cons and reasons to go to either one. Honestly, there's a ginormous demand for techs right now in the field. The rate of new techs in the field, coming into the field every year, is far below what we actually have. So it doesn't matter what school you go to. If you go to one and get educated and you have a passion for it, that's all that really matters.
Very, very true. Just getting an idea of where a technologist can play a role, just to reiterate, you could be in the operating rooms, in intensive care units, you can be in outpatient labs, right? You can be a part of research, biofeedback labs as part of it as well, doctor's offices or vendors. There's many different avenues, and I think this offers up a lot of opportunity if this is a field that you want to get into. And here, just even as an example of some of these, and where you might be exposed to, I think it's good that even if you go to this, if you get into a program and look at it, it could be a starting point for you to branch into something else if you want it for healthcare as well. As Jay was stating, there's some pros and cons. The earnings, I think there might be a little bit higher than what you have on there, depending on location and where you're at, right?
Highly varies by region.
Yes.
These were based on the ASET salary.
Yeah,
On a national field, which is taken into account areas which have
absolutely.
lower scales.
Just in my own experience, of course, I'm in the Bay Area, cost of living is higher, something to take into consideration, but our salaries are competitive and comparable. I've been on assessment for the last 5 to 6 years to make sure that we meet that, because of retention purposes, things along those lines. But you think about it, you can go anywhere on a national level, even international, because we're looking at outreach and how to help support on an international level, third-party countries, things along those
It's
lines.
competitive to nursing.
Yes, absolutely, absolutely.
The job itself is in some ways better because you don't have to work 72-hour weeks unless that's what you really choose. And so you can have a normal 9 to 5 and you can go to work, go home, take call every once in a while if you want to, and you don't have to worry about sputum and this and other stuff.
And depending on the environment and where you're at, there's some models where it's 24/7. For our organization, we have 2 hospitals and we're 24/7 staffed 7 days a week, 365 days a year. And our staff, they have 4 10-hour shifts. So you look at quality of work-life balance, we try to meet that as well. So knowing that you have options, depending on what enterprise you go into. Going back to some of the credentialing, these are some of the things to look for credentialing when you have a technologist doing and conducting one of your tests. And as we talked earlier about why credentials are so important, because you want to make sure the person is educated and knowledgeable. And also, they're only seeing you for a short period of time, but they play such a vital role in your workup. And you want that first assessment to be correct, if you will. I think you talked a little bit about lab accreditation. Did someone mention that?
No, we're doing the lab accreditation.
So looking at centers and making sure that they're accredited just means that they uphold standards on a national level. They have all the requirements and expectations in their lab to be able to say we are doing this proficiently and correctly. And then these are some of the accreditations that may fall into from an EEG lab to intraoperative monitoring and as well as long-term monitoring as well. Okay, so I think we're in closing. Does anyone have any questions? I know there's a lot of data. We're just sort of giving you bits and pieces, and I love the engagement and feedback because this is what we want, and it helps us even for the future in knowing what best to talk about if this is something that's very helpful or we want to sort of change the dialogue for next time. Okay, and here is a website for ASET. You can go there. It's a one-stop shopping for careers, for education, the schools, the type of procedures, competencies for us to do our work. All of that information is listed there.
So ASET.org.
Any questions?
If you guys find out you have any questions later on, we'll be at the ASET booth, and I'll be kind of tag teaming ASET and Concord. So if you have any questions on what it takes to be a tech, the education aspect, or what it's like on the job, different specialties that you can be in, or anything else whatsoever, we'd be happy to take it. The education for an accredited program is usually a 2-year education.
There's online programs that you can do it in just about a year. And it is accredited, at least one of those two is accredited.
There's Seizure programs as well. So you have options.
But with that type of program, you're only going to learn one test where you have to sit down in classrooms that last 18 months to 2 years. You're going to learn about EEG, the long-term monitoring, intraoperative monitoring, the evoked potentials, transcranial Dopplers, nerve conductions. You end up learning a whole lot.
I mean, just myself, I teach evoked potentials, nerve conductions, neuroanatomy, physiology.
You get a little bit of background in
There's
college,
a lot of anatomy, very science-driven. It's not so much math-based heavily, although there is some math. Very science-based.
Very science-based, absolutely, absolutely. Any other questions? Okay, so you'll know where to find us. We're here all day, today and tomorrow. So thank you so much for everything.
Thank you.